The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at podcast.asco.org. My name is Brittany Harvey, and today Dr. Nadine Tung from Beth Israel Deaconess Medical Center in Boston, Massachusetts is here to discuss the management of hereditary breast cancer, American Society of Clinical Oncology, American Society for Radiation Oncology, and Society of Surgical Oncology Guideline. Thank you for being here today, Dr. Tung.
My pleasure. Thanks so much for inviting me.
First, can you give us a general overview of what this guideline covers?
Sure. There has never previously been an ASCO guideline to address how best to manage breast cancer patients with an inherited risk, even for BRCA1 and 2, for which there is the most data. There's been a lot of controversy regarding the optimal local and systemic treatment for patients with hereditary breast cancer. Even for patients with inherited BRCA mutations, for whom we've been caring the longest, is radiation contraindicated? Is breast-conserving therapy a reasonable option? Is platinum chemotherapy preferred? How shall PARP inhibitors be used? And then for patients with the more recently tested genes like ATM, CHEK2, PALB2, same questions. So ASCO joined forces with ASTRO under the leadership of Lori Pierce and Judy Bowie from the Society of Surgical Oncology to develop guidelines that addressed issues of both local and systemic therapy for these patients. And I do want to recognize Dana Zakalik, my co-chair, who could not be here today with us. We focused on the 5 most common genes for which inherited mutations are associated with breast cancer, namely BRCA1, BRCA2, but also PALB2, CHEK2, and ATM. Now, BRCA1 and 2 are high-risk genes. CHEK2 and ATM are much more moderate-risk genes. And the risk associated with PALB2 mutations is closer to BRCA1 and 2, and we really consider it a high-risk gene. But in this guideline, we tend to group BRCA1 and 2 recommendations together because there's much more data. And then PALB2 is grouped with ATM and CHEK2 as, quote, more moderate risk genes, simply because there's much less data for these 3 more recently identified genes with regard to local and systemic therapy.
And what are the key recommendations of this guideline?
Well, let's break it down into local and systemic therapy. So if we start with local therapy and we start considering patients with BRCA1 and 2 mutations. First, breast-conserving therapy may be considered for appropriate patients since the local control of the index cancer is similar to that for women who do not have a BRCA mutation. Certainly, a discussion of bilateral mastectomy is warranted due to the increased risk for both an ipsilateral new future breast cancer and the significant risk, particularly in younger women, of a contralateral breast cancer in the future. We do highlight in the recommendations that age at diagnosis is the strongest risk for developing a contralateral breast cancer over any time period, as younger age at diagnosis probably reflects stronger environmental and genetic inherited modifiers. Being able to provide BRCA carriers with breast cancer an accurate risk of their future contralateral breast cancer is very important in helping our patients decide on the right surgical choice for them. We actually provide a table in the guideline derived from existing literature that indicates the risk of a contralateral breast cancer over various time periods based on a woman's age at initial breast cancer diagnosis. So that's for women with a BRCA1 or 2 mutation. For patients with more moderate risk mutations, ATM, CHEK2, PALB2, there's really a lack of data regarding the risk of a future or contralateral breast cancer, except for one particular CHEK2 mutation, the 1100 del-C mutation. For patients with that particular mutation, the risk of a contralateral breast cancer is about 3-fold higher. So in general, decisions about local surgery should not differ based solely on finding that your patient has one of these more moderate risk mutations. Other risk factors, such as patient's age at diagnosis, their family history, should be considered when making decisions about mastectomy or prophylactic mastectomy versus breast conservation, as we would do in any other patient. And then for women with BRCA1 or 2 or more moderate risk gene mutations who choose to have a mastectomy, we recommend that nipple-sparing mastectomy is a reasonable option if it's otherwise medically appropriate. So in turning our attention to radiation therapy and whether that's safe for our patients with these inherited mutations, again, let's start with patients with BRCA1 and 2 mutations, but really for women who have any of these mutations, BRCA1 and 2 or the more moderate risk mutations, there is no data that radiation therapy increases either local toxicity or a contralateral breast cancer. So it should be offered when indicated. Now, the only exception is for patients with inherited P53 mutations, women who have what we know as Li-Fraumeni syndrome. For those patients, radiation therapy is contraindicated due to the increased risk of radiation-induced second cancers like sarcomas. And so for those patients with inherited P53 mutations, mastectomy rather than breast-conserving therapy with radiation should be offered. And radiation should really be reserved for those at significant risk of local failure after mastectomy. There's been a lot of controversy regarding whether radiation therapy increases local toxicity or contralateral breast cancer in women who have inherited a single ATM mutation, either from their mother or father. After reviewing the existing data, the committee feels that radiation should be offered to these patients. There's just insufficient data to withhold it. It is important to understand that many of the variants that are called mutations in the literature are really gene changes with unclear significance, which makes reviewing the literature even harder and much harder to interpret. The bottom line, ATM mutation carriers should be offered breast-conserving therapy with radiation if they are candidates for this option and desire it. So finally, in asking what are the guidelines or the most important parts of the guideline, let's turn our attention to the systemic therapy recommendations. And again, we'll start with the BRCA mutation carriers. So the first recommendation is that for the BRCA carriers with metastatic HER2-negative breast cancer, PARP inhibitors should be offered rather than non-platinum chemotherapy in the first to third line setting. And this recommendation derives from the two large phase 3 randomized trials, Olympiad and Embraca. They are the trials that led to the FDA approval of olaparib and talazoparib for BRCA mutation carriers with metastatic breast cancer. And the use of a PARP inhibitor in those studies really led to better progression-free survival, response rates, and quality of life compared with the chemotherapy administered. The time to response was the same as with chemo, and the responses were seen in patients with both estrogen receptor positive and triple negative disease. There has not been any study that directly compares PARP inhibitors with platinum-based chemotherapy at the time of the guidelines. PARP inhibitors cannot yet be recommended for BRCA carriers with early-stage breast cancer, We're still awaiting the results of several trials. And then with regard to the recommendation of platinum chemotherapy for BRCA mutation carriers, in the metastatic setting, platinum should be used or considered in lieu of a taxane in the first-line setting, and especially for our patients with triple-negative disease. That is based on the TNT trial. That study demonstrated a higher response rate and better disease-free survival using carboplatin than with docetaxel in the BRCA carriers. However, the committee really found that there was insufficient data to routinely add platinum chemotherapy to standard anthracycline and taxane-based chemo for BRCA carriers with early-stage breast cancer. And that recommendation really derived from two trials, the GEPAR-6DO trial and the Brightness trial, which was from I-SPY. Those were neoadjuvant trials that failed to demonstrate a significantly higher pathologic complete response rate or better outcomes with the addition of platinum for BRCA carriers. And finally, if we consider ATM, CHEK2, PALB2 mutation carriers, and we think about what systemic therapy to use, we do not really have any data about the benefit of either PARP inhibitors or platinum-based chemo for those breast cancer patients with those mutations. So we await the results of ongoing trials.
Thank you for reviewing those recommendations. So can you speak to why this guideline is so important and how it will impact practice?
Sure. Prior to these guidelines, I would often hear in meetings that patients with BRCA mutations must have bilateral mastectomies. And for a 60-year-old mutation carrier with her first breast cancer, I think that woman has a choice and should be informed of her risk of a second or contralateral breast cancer in order to help her make the most evidence-based choice, the one that's right for her. Likewise, for a woman with an ATM or CHEK2 mutation carrier who is eligible for breast conservation, that woman should be offered breast conservation. And it's important not to miss our metastatic breast cancer patients who do have an inherited BRCA mutation so that they can be offered a PARP inhibitor, which is more effective and generally less toxic than chemotherapy. And finally, it's important to understand when platinum chemotherapy is and is not indicated. Adding platinum to standard chemotherapy introduces a lot of toxicity, and routinely adding it to regimens, for example, for BRCA mutation carriers in the early setting, really just can't be supported by existing data.
And finally, you've spoken to this a bit, but how will these guideline recommendations affect patients?
I think whenever clinicians are practicing based on the best evidence available, it benefits our patients. These guidelines will help patients, again, make the most evidence-based informed decisions regarding both their local and systemic therapy.
Great. Thank you for your time today, Dr. Tung, and for working on these guidelines. We really appreciate it.
My pleasure. Thanks so much, Brittany.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/breast-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.